For a long time, chemotherapy, platinum-based doublet has remained the standard of treatment for advanced non-small cell lung cancer, even for frail elderly patients. For more than 10 years, several driver mutations have been identified in non-small cell lung cancer, especially in adenocarcinoma. Part of them are real major driver mutations. For example, EGFR, ALK translocation, ROS1 translocation, and BRAF mutations, for example. EGFR mutation, which has been the first to be identified in 2004, is the most well-known. We have now 3 drugs that have obtained their regulatory approval in a first-line treatment in EGFR mutated patients. We have a great efficacy with this treatment, and the profile of tolerance is good, even for elderly patients. We have some phase 2 trials that have demonstrated that the outcomes in terms of efficacy are quite equivalent to what have been identified in younger patients with a good toxicity profile. Unfortunately, we have an inevitable progression in the EGFR TKIs in these patients, and we have now identified several resistance mechanisms, and the most frequent is the T7090M mutation. This, which occurs in near 60% of the patients. And this is a key challenge for the clinicians to identify this T7090M mutation, because now we have a new drug, a third generation EGFR TKIs, that has demonstrated that is able to overcome this resistance mechanism. We have a phase 2, a phase 1, and then after more recently a phase 2 trial that has demonstrated that in this specifically population of T7090M positive patients, we have under osimertinib an overall response rate of 70%, with a great median PFS of 9.9 months. This is quite equivalent to what we had in first line, in fact, in these pre-treated patients. We can now identify this mechanism of resistance, the T7090M mutation, by plasma genotyping, with a great sensibility of 70%. Of course, if the plasma genotyping is negative, the clinician must try to obtain a biopsy in order to realize the analysis of the T7090M genotyping. After the EGFR, we have also the ALK translocation and the ROS1 translocation, who occurs in near 4% for ALK translocation and 2% for ROS1 population. That occurs predominantly in young patients. These 2 drivers confer a great sensibility to crizotinib in first-line treatment. And for ALK translocation, who progressed after first line by crizotinib, we have new drugs, for example, the ceritinib, which is efficient, and new drugs like brigatinib, lorlatinib, and in the near future, alectinib are available. Another predominant driver is a BRAF mutation. BRAF mutation occurs between 2 to 4% of the non-small cell lung cancer, and the median age of this population of patients is near 65 years old. That means that we can have elderly patients with this BRAF mutation. We have now a phase 2 trial that enrolled patients with a V600E BRAF mutation, and especially one phase 2 that evaluate the association of dabrafenib, an anti-BRAF, plus trametinib, an anti-MEK compound, with a great efficacy. The overall response rate is 63%, and the median PFS 9.7 months. Of course, we can have some toxicities, but that seem to be manageable. We have no specific data in elderly population with BRAF mutation. And I will finish with an emergent driver, which is less known, which is the MET exon 14 skipping mutation that occurs in 2 to 3% of the patients. And what we can note is that the median age of the patients with this alteration is 73 years old. That means that we have a real elderly patient with this mutation. This mutation confer a sensibility to crizotinib. So, of course, we need prospective data to confirm the efficacy, but I think that can be easily research that can be identified, more than research, that can be easily identified by next generation sequencing techniques that, for example, we have available in our center. So this is an emergent driver that we'll have to keep in mind for the future. In phase 3 trials, there are few data concerning the elderly patients, but we have case reports that show that we can have real encouraging results with these compounds. Yes, I think that trials specifically dedicated to this population of elderly patients will be soon available. Remaining questions is, of course, whatever we talk about targeted therapies or immunotherapies is how we'll fund all these drugs in the future, because all of them are very expensive.